and all their team of MAPICON for giving me a chance to speak on today's topic, endovenous lesion treatment. Coming to the definition of varicosity, varicose vein is a later stage, but before that there is telangiectasis, there are reticular veins, and after that comes the varicose vein. Now, what are the varicose vein? All the students sitting here must be knowing that these are subcutaneous dilated veins which are more than 3 millimeters of size, and they have lost their walls, and most of them are saphenous, great saphenous, small saphenous, and their tributaries. There are few pictures of telangiectasis, reticular veins, and varicose veins. Now, coming to the common questions which are asked: are they dangerous? How do they form? Why does it happen? Did I inherit it? What test can be used? And what treatments are available? As we all know, there are two main systems of superficial veins: great saphenous vein, which ascends anterior to the medial malleolus and posterior to the medial condyle of femur, and it communicates with the small saphenous vein also. It traverses to the saphenous opening in the fascia and enters into the femoral vein. Another is small saphenous vein, which is formed by the union of dorsal digital veins at the 5th digit of the distal venous arch, runs posteriorly to the lateral malleolus and between the calcaneal tendons, and then it dips into the popliteal fossa into the popliteal vein. There are perforating veins also. These perforators separate or communicate superficial veins with the deep veins, and there are two types of the perforators. These are indirect perforators, which takes the blood from the superficial veins to the muscles and then indirectly into the deep veins, and another are direct perforators, which directly communicate the superficial veins to the deep veins. There are so many names of direct perforators. Of these are Hunterian perforator, Dodds perforators, Boyd perforators, Cockett's perforators. These perforators enter into the deep veins obliquely, so that when the deep veins are working, that is, when their musculature are working, these perforators get occluded and they do not allow the blood to flow from the deep veins to the superficial veins. Deep veins usually are paired with the name of their arteries, and inside the deep sheath, and now coming to the etiology of telangiectasis and varicose vein, 80% of the reason is reflux, and another reason is venous obstruction, which results into edema and skin changes and post-thrombotic syndrome. And the most important is muscle pump dysfunction. When the muscle stops functioning properly, they allow and the walls of perforators become incompetent. They allow the blood to flow from the deep veins to the superficial veins, and these things cause elongation of the superficial veins, tortuosity develops, and they become varicose veins. Now, coming to the pathophysiology of the varicose vein, usually it is associated with the venous incompetency. There are walls in superficial veins which becomes incompetent, and instead of going to the heart, blood starts pooling into superficial veins, and they become tortuous. This leads to primary and secondary reflux, edema develops, vein walls dilates, and inflammation, pigmentation occur around the veins in the skin because of deposition of hemosiderin, and which ultimately leads to fibrin cuffing and ulceration in the skin. Risk factors: age and wear and tear. These are the two main things which result. Later the age, more are the chances of developing varicose vein. As we come to the gender, women are more predisposed to the varicosity than the men. This is because of hormonal changes during pregnancy and at menopause. Progesterone is known to relax the venous walls, and OCP may also increase the risk of varicose veins. Genetics is also associated with the varicose vein. This disease comes in the families also. Obesity can increase the chances of varicosity because of venous hypertension. And coming to the occupation, prolonged standings are also known to be risk factors for varicosity. There is strong familial component associated with the varicosity. In identical twins, there are 75% chances of varicose veins in both the siblings. Coming to the symptoms are achy and heavy feeling and burning, throbbing, muscle cramps, etc. in the calf region and the thigh region. Prolonged sitting or standing tends to intensify the symptoms. Pruritus can occur, and ultimately it can lead to painful skin ulcers, which becomes non-healing till the venous varicosity is treated. Complications: extremely painful ulcer may form on the skin near the varicose veins. Brownish pigmentation can occur, and occasionally the deep veins can bleed, and superficial thrombophlebitis can occur. Coming to the indication for EVLT. EVLT is endovenous laser treatment. As I am doing EVLT, I will be more speaking about the EVLT, not about the radiofrequency. Lessons from American venous form. The things have been categorized on the clinical, etiological, anatomical and pathophysiological basis. There are these are few categories, C0 to C6, depending upon the non-visibility of depending upon the visibility of the venous disease, and up to skin changes previously in the previously active lesion up to C6. Etiology can be congenital, primary, secondary. Anatomical, it can be superficial veins, perforator veins or deep veins. Pathophysiological classification is reflux, obstruction or both. The most commonly we get patients from C2 to C6 level. Patient assessment is on the history. You all know about the history of the symptoms, history of the venous complication, whether the patient is willing to get treated or not, comorbidities like ulceration or bleeding, and but before that you will have to rule out the secondary cause, DVT and heart failure, etc. Examination, I won't go in detail because nowadays examination is solely based on Doppler studies. Coming to the investigation, all the patients are supposed to get duplex scan so that we can come to know the tortuosity of the veins, so that we can come to know the competency of saphenofemoral junction, so that we can come to know the competency of popliteal junction, deep veins, perforators, etc. There are some tests which are not commonly done, and I won't mention them here also. Treatment in the C0 and C1 level, we can get it treated through the conservative, that is leg elevation, asking the patient and changing his habits of walking, compression stockings, and treatment of underlying causes, etc. But vein ablation therapy, these are required from C2 to C6 level patients. Vein ablation therapies are of or vein ablation or vein treatment therapies are of three types. Number one is chemical therapy, that is sclerotherapy. Number two is thermal, which is laser ablation and EVLT. And number three is mechanical or surgical excision or stripping. Now, who are the candidates for sclerotherapy? These are the person who have small non-saphenous varicose vein less than 5 mm, say telangiectasis, etc., residual or recurrent varicosities after surgeries, where small veins and telangiectasis or spider nevis are there, reticular veins are there. These are the good candidates for sclerotherapy. What sclerosing agents are being used? There are so many, but in our practice we are using sodium tetradecyl sulfate as a sclerosing agent, which damages the endothelium and leads to thrombosis of the veins. We keep the pressure so that the amount of thrombus remains less and there is no thromboembolic phenomena. Microsclerotherapy, this is a picture of microsclerotherapy. It needs a few sessions if there is recurrence, and it is done by 30 gauge butterfly needle with 0.2% sodium tetradecyl sulfate. Foam sclerotherapy. This is known as foam sclerotherapy because when we take sodium tetradecyl, we take air with it in a ratio of 1:4, so that we shake it in a way in 2 syringes so that there becomes foam. Why we need foam? Because foam induces spasm in the vein, and foam disperses further very fast, and it enhances the sclerosis. This is a picture how we take 1 ml of sodium tetradecyl and 4 ml of air, and we mix it thoroughly 25 times so that there becomes a good foam. This is a pre and post picture of spider vein. There are few complications associated with the sclerotherapy, which are phlebitis, skin staining, failure, residual lumps, matting, embolus. CVA can occur, but if you are aware enough and if you are keeping pressure on the proximal part, and if you are confident that you are not dealing with the perforated so that sclerosant goes to the deep vein, then there is no fear of embolus or DVT. Ulceration can occur or anaphylaxis can occur in very rare cases. Foam sclerosing therapy results are very good when it is used in less than 5 mm of the size veins, but in large veins this cannot be used. Now coming to topic of my interest, which is endovenous laser ablation or endovenous laser treatment. It is EVLT. Primarily it is to treat saphenous insufficiency, that is great or small saphenous vein. EVLT and RF ablation both are equally efficacious. This is a picture of radio frequency ablation instruments. Now coming to this topic, endoluminal radio frequency ablation of great saphenous vein method. Under the sono guidance, we put a 16 gauge cannula just above the knee and under the duplex ultrasound. Then we put a guide wire through this, which we trace up to the cephalofemoral junction, and over that guide wire we push a sheath, and through the ultrasound guidance we make it sure that it remains 3 cm distal to the cephalofemoral junction. Then after pushing the sheath, we push the laser probe. This is a laser probe. We push the laser probe with a pilot beam, and along with this ultrasound verification, when we illuminate the pilot beam, it gives us the impression where that actually is, and we can manually take note of that it is 3 centimeter distal to the saphenofemoral junction. Then these are few machines which are known to produce this machine. This therapy is based on photothermolysis, which causes the thermal damage to the endoluminous of veins. The laser light heats the target tissue, including thermal injury. What is the mechanism? It damages the endothelium, internal elastic lamina, and up to some degree to the media. Adventitia is rarely affected. In vitro studies suggest that energy results in boiling of blood and generates stream of bubbles that indirectly but homogeneously affect the varicose veins. Now this is a fastly I will review the method. GSV is entered at the knee, guide wire is passed through the hollow needle. If difficulty in the form of tortuosity and local venous spasm and sclerosing fragment, needle is removed, 3 mm cutaneous incision is given, introduces sheath is placed over the guide wire removed when SFJ is reached, longitudinal ultrasound visualization of sheath 1 to 2 cm, but we prefer 3 cm distal to the SFJ. Tumescent anesthesia comprising of 5 ml of epinephrine, 5 ml of bicarbonate, sodium bicarbonate, and 35 ml of 1% lidocaine in 500 saline bottle is taken, and it is administered around the perivenous space around the sheath, which it reduces the pain, it protects the perivenous tissues like sural nerve, etc., increases the surface area of laser tip and venous wall. We use pulsed and continuous vein. Few people do it under local anesthesia, but we are doing it under spinal anesthesia. Fiber is withdrawn, then pilot beam is off, is set to the off, and we start the laser beam, and we keep on withdrawing the laser fiber at the rate of 1 to 3 mm per second under ultrasound guide. Here the ultrasound probe also acts as a pressure device over the vein so that it occludes properly. After that, immediately after the procedure, compression stockings are given. Patient can be discharged on the same day if we are doing it under the local anesthesia, but as we are doing under spinal anesthesia, we discharge patient on the next day. Post-op care is not a big deal. Graduated compression stockings, follow up with the duplex ultrasound. Patient recovery is averagely it is in 2 to 3 days. It has got very shorter interval than with the surgical ligation or stripping. Complications can also occur with the EVLT: pain, bruising, hematoma, skin changes, burns, induration, matting, dysesthesia, superficial thrombophlebitis, nerve injury. DVT can also occur if we wrongly enter into the deep system. Wound infection is also having few chances. Which is better? Endoluminal thermal ablation versus stripping of the saphenocin. Which is better? Both are having equal results, but as EVLT, in EVLT you can go to your work in 3-4 days. It is considered to be better, and it is a non-invasive procedure. Here are here is a comparison and advantages and disadvantages of EVLT. EVLT is a minimally invasive procedure, no post-op scar, done with the local anesthesia, minimal post-operative pain, recurrence rate is less than 3% at 2 years. At our center, it is less than 1%. Disadvantages are, it is a costly procedure because machines and fibers are costly. Earlier we were, and of course the another thing is greed of the surgeon. Earlier we were doing it at a rate of 40,000 per leg, but now we have reduced the rate to the 25,000. It needs high technical skills. Color Doppler skill is also required, and skin burn, thrombophlebitis and paresthesia can occur. at times. Conclusion: catheter-based treatments are traditional and traditional venous stripping with the high ligation have similar long-term results. Catheter-based treatments have a decreased post-op pain, shorter recovery time to work and normal activity. This is my hospital, Chhabra Hospital and Test Tube Baby Center. This is a small video, testimony video of a patient of 20 seconds. I want to play for you. Will you play it? Will you play it?
मेरा नाम ਮਹਿੰਦਰ ਸਿੰਘ ਪਿੰਡ ਗਾਲੋ ਕਲਾਂ। ਮੇਰੇ 15 ਸਾਲਾਂ ਤੋਂ ਲੱਤ ਉੱਪਰ ਬਹੁਤ ਜ਼ਿਆਦਾ ਨਾੜਾਂ ਖੜੀਆਂ ਸੀ। ਮੈਂ 11 ਤਰੀਕ ਨੂੰ ਡਾਕਟਰ ਵਿਕਾਸ ਛਾਬੜਾ ਜੀ ਤੋਂ ਲੇਜ਼ਰ ਰਾਹੀਂ ਆਪਰੇਸ਼ਨ ਕਰਾਇਆ। ਜਦੋਂ ਅੱਜ 16 ਤਰੀਕ ਨੂੰ ਪੱਟੀ ਖੋਲ੍ਹ ਕੇ ਦੇਖੀ ਉਹ ਬਿਲਕੁਲ ਗਾਇਬ ਸੀ। ਅੱਗੇ ਵੀ ਸਾਰਿਆਂ ਨੂੰ ਬੇਨਤੀ ਆ, ਤੁਸੀਂ ਛਾਬੜਾ ਹਸਪੀਟਲ ਬਠਿੰਡਾ ਤੋਂ ਹੀ ਲੇਜ਼ਰ ਰਾਹੀਂ ਆਪਰੇਸ਼ਨ ਕਰਾਓ। ਬਹੁਤ ਵਧੀਆ ਆਪਰੇਸ਼ਨ ਹੋ ਰਿਹਾ। ਮੇਰਾ ਨਾਮ